Hi. Hi, good morning, everyone. Hi, Dr. Paul. Thank you very much for joining us. So, Dr. Paul is head of the Ophthalmic Genetics Division of the KZI Institute in Portland, Oregon. And he's going to talk with us about genetics, uveitis, and um, other topics. Thank you very much again, Dr. Paul. I know it's very early in Portland right now, and if you are ready, you can start sharing your screen and
Okay.
start your talk.
All right. Okay. Well, thanks for having me. Can you see my PowerPoint?
Perfect, yes.
Okay, very good. Well, thanks for inviting me to talk. This is one of my favorite topics. I'm happy to share these cases with you and some of my thoughts and pearls surrounding this area of overlap between genetic disease and uveitic masquerades. Okay, there we go. These are my disclosures, but none of these are relevant for my talk today. So I'm going to be going over a few themes today. One of them is just a brief discussion of the immunology of inherited retinal degenerations, like retinitis pigmentosa, just to kind of get us on the same page before we start getting into inflammatory overlay versus masquerades. And then I'll also be covering a little bit of gene therapy associated uveitis and IRDs. And then finally, just a brief review of inherited types of uveitis. So this is just a brief review of the immunology of IRDs. What we know about it comes mostly from animal studies. But here's a schematic of the photoreceptors and microglia and Mueller cells. And so during retinal degeneration, damage-associated molecular patterns, or DAMPs, are liberated. And phosphatidylserine, PS, is expressed on stressed photoreceptors, which are likely acting in concert to trigger microglial activation, as well as activation of bone-derived macrophage infiltration. So that's the innate immune response. And it's modulated by many intracellular signals. Neuroprotective factors such as TGF-beta, IL-10, as well as chemokine fractalin, which is CX3CL1, as well as glial cell line-derived neurotrophic factor, GDNF, and leukemia inhibitory factor, LIF. There's also pro-inflammatory factors. So these are cytokines, IL-1, IL-6, TNF-alpha, as well as nitric oxide. And there are these pattern recognition receptors for DAMPs. One of the big categories are these TLRs, or toll-like receptors, as well as NLRPs, nucleotide binding polymerization domain-like receptor. And so this is a schematic of a microglia. Express receptors for IL-1, as well as CX3CL1. And they go through these important adapter molecules, such as MIDI88, which are adapter molecules for TLR and the IL-1 pathways. And all of these pathways compete for a net response that can activate the microglia and the macrophages to express TNF-alpha and nitric oxide, which are cytotoxic, as well as interleukin-1, IL-6, and interferon, which can promote an adaptive immune response. So ultimately, microglia and macrophages are capable of assuming a M1 phenotype, which is pro-inflammatory, or M2 phenotype that's neuroprotective. That is a little bit oversimplistic. We know now that M1 and M2, those are extremes, and that microglia can exist in gradations between the M1 and M2 phenotypes. Okay, so that was a really brief overview of what we think is going on in patients with retinal degenerations. So with that being said, I think you'll agree with me that I think it's not surprising that we're going to see some clinical signs of inflammation in some patients with IRDs. Okay, so this is the second theme, right? Inflammatory overlay versus masquerade in IRDs. So, you can imagine that these complex immune pathways can lead to a pro-inflammatory state in IRDs. We're still learning more about this, and so this is kind of an emerging area of study. So within this theme, I'm going to go over things that leak in IRDs, so clinically, things that you might see. Also, we're going to go over atypical patterns in IRDs and what might be causing those atypical patterns and how it can masquerade as uveitis. And then another one is atypical timing, late onset. Typically genetic disease, we think it starts early in life, early to mid phase in life, but there are these late onset types of IRDs, which we're only now knowing more about, which can masquerade as acquired conditions. So things that leak. Now, one of the most common things that you will see in inherited retinal degenerations, especially retinitis pigmentosa, is leaking cystoid macular edema. So shown here is a patient with RP, retinitis pigmentosa, due to a mutation in rhodopsin, one of the most common types of dominant RP. And even just on clinical exam, you'll often see 1+ cell in the anterior vitreous. And then as shown here, there's cystoid macular edema on fluorescein angiography, and you can see that it leaks with the kind of this petaloid cystic appearance. And you can see a very severe macular edema on OCT. What's interesting is if you look at the visual acuity here, it is decreased, but it's not that bad. It's 20/30, 20/40. Compared to if this was uveitic, right, macular edema, the visual acuity might be worse than that. So there is something different about the macular edema and retinitis pigmentosa. We're not quite sure if this is truly inflammatory or just the sequelae of retinal degeneration. You'll also notice in the on the left panel, the fluorescein angiography in the early phase, that next to the macula, there's kind of this perivenular hyperfluorescence juxtaposed to a periarterial hypofluorescence. So when you look at that, you might be inclined to think it's some sort of vasculitis, but I don't think it is. It's probably due to a difference in the metabolic state of the degenerating retinal tissue, and thereby giving you a differential in the fluorescence pattern between the periarterial areas and the perivenular areas. Okay, so here's another patient, retinitis pigmentosa, also due to rhodopsin, half plus pigment in the anterior vitreous, pigmented cells in the anterior vitreous, also with leaking macular edema. But here we have the fluorescein angiography focused on the periphery. This is the nasal periphery. And again, you see this feature that I talked about, a perivenular hyperfluorescence juxtaposed to a periarterial hypofluorescence. Okay, and again, you will see these, and they tend to occur in the areas, we call it the transition zones. These are the areas where there's kind of active degeneration. Other things you will see is disc leakage and retinal leakage in IRDs. This is another case of RP, but it's due to a gene called RPGR, 9-year-old. And there's 1+ cells in the anterior vitreous. Also leaking CME, and in this case, you will see on the fluorescein angiography leakage of the disc, and also leakage of the retina inferior to the disc. Okay. And you can see the optic nerve, OCT of the optic nerve, showing that it's kind of a full disc. To be sure, we did do an MRI brain in orbit, and that was negative for any other etiologies. So this is yet another possible, sign of inflammation in RP. So now we're going to switch over to a different type of inherited retinal degeneration called autosomal dominant vitreoretinal choroidopathy. It's due to a mutation in a gene called BEST1. In this case, you're going to get leaking CME, leaking disc, and leaking retina. Again, half-plus pigmented cell in the anterior vitreous. And then on the angiography in early phase, you'll see diffuse retinal choroidal atrophy, window defect. And then in the late phase, you see all those elements, right, of leaking CME, leaking disc, leaking retina. And then on OCT, you see vitreoretinal traction and macular edema. And so that previous case was the mother, and this is the son. Just to kind of give you another look at what it looks like earlier in life. You still see a lot of the same features, right? CME leakage. In this case, you do see something more with the vessels. You see the kind of this venous staining, right? And then on OCT, again, macular edema and some vitreous retinal traction. Okay, so this is yet another condition called snowflake retinal dystrophy. And in early phase disease, the posterior pole looks pretty normal. And not until you look at the periphery do you see these yellow deposits. And on fluorescein angiography, you see that there's kind of diffuse peripheral retinal leakage, right? These are areas of degeneration. Okay, and that was actually the daughter. This is the mother, and you can see, right, much more advanced. The degeneration has progressed into the posterior pole, right? That posterior pole no longer looks normal. You see macular atrophy. You see vascular sheathing. There's retinal edema with leakage, as well as vascular staining on fluorescein angiography. So this is a case of severe early childhood onset retinal dystrophy. That's a broad category. There's many different genes that cause degeneration early in life within the first decade of life. This is one of those. So 12-year-old, there's 1+ cell in the anterior vitreous, and then there's this peripheral lesion, right, that looks exudative. And then on angiography, you see there's abnormal vasculature with leakage. And then there's macular edema. So this is a Coates-like lesion with leaking macular edema. This is interesting. We don't know what causes it, but we do know that this is yet another finding in IRDs. All right, so here's another one that can mimic. So autosomal recessive bestrophinopathy due to biallelic mutations in a gene called BEST1. So this is a 7-year-old, and you see immediately, right, on the fundus photos that there are these multifocal yellow lesions. And on fluorescein angiography, they stain. There may be pooling, but there's really not too much leakage. On OCT, you can see that there's subretinal fluid, and there's these subretinal, some of them even look sub-RPE deposits. And then there's macular edema. So this can be a masquerade, for another condition called acute exudative polymorphous vitelliform maculopathy. Okay, so this other condition, right, is a rare retinopathy associated with melanoma and carcinoma. So it's really important to tease these things apart, right, because there's implications for systemic etiology. And in this condition, you also see these vitelliform deposits, right? You can see the OCT looks very similar with these multifocal subretinal fluid and detachments. Okay, so it's important to be aware of how this can masquerade with each other. All right, so I'm going to switch gears again, right? So we're still within the theme of masquerade, right? Now we're going to talk about atypical patterns. So this is a table that illustrates how complex it can be. When I talk about atypical patterns, I'm talking about atypical between the right and the left eye, meaning is it symmetric, right? So with genetic disease, we tend to think it's usually symmetric in both eyes. But there's exceptions. There's asymmetry. Then there is also the pattern of the degeneration within each eye, right? There's kind of this idea of a textbook typical pattern. So for example, retinitis pigmentosa, you tend to see degeneration in the mid-periphery and the periphery. Starts there and then it kind of goes towards the center, right, of the eye. That's retinitis pigmentosa. And then in other cases like Stargardt disease or cone dystrophies, it's the opposite, right? Starts in the center in the macula and it goes outwards, right? Those would be the typical patterns. Well, it's not so simple. There are also atypical patterns. There are different variant phenotypes, even just for retinitis pigmentosa, right? There are these phenotypes where the involved area is not the mid-periphery, it's pericentral, or it's concentric all the way out in the far periphery, or it's sectoral, only a zone of the retina appears to be involved. And there are certain genes associated with each of these type of phenotypes. On the side of asymmetry, we can see the kind of asymmetric patterns between the right and the left eye when patients have what we consider somatic mosaicism. That means not every cell in their body has the same genetic mutation. Okay, and then there's also the most complex one, which is it's different between the right and the left eye, and within each eye, it looks atypical. And so that can also happen with somatic mosaicism, but it can happen often with X-linked female carrier state disease. And that's due to kind of X inactivation, a skew in X activation, and there's kind of a randomness sometimes to the cells that have the mutation. So we're going to start with the first one here, which is symmetric between the right and the left eye, but in each eye, okay, even though it's symmetric, it doesn't look like the typical type of degeneration. And here's one of those. So this is retinitis pigmentosa due to a mutation in a gene called EYS, right? Looks pretty symmetric between the two eyes, but right, this is not what you normally would expect to see as a mid-peripheral or peripheral degeneration. This is a pericentral with some peripheral involvement. Now, the one thing to differentiate here is to distinguish it from the differential of MORR, which is a relatively new variant of Azor. It's called multizonal outer retinopathy and retinal pigment epitheliopathy. So that's what that looks like. So if you probably agree with me that there's definitely a phenotype overlap here. So this is considered a variant of Azor. Whereas RP is chronic and progressive, right? Azor and variants of Azor like this one tend to have acute onset, and is episodic. Okay, and this specific variant, right, has central and peripheral zones of involvement. Over time, you can see the affected areas will develop RP-like pigment changes, as well as narrowing of vessels. Okay, and in this case series, published in 2023, all these patients had negative uveitis workup and negative genetic testing. So be aware of this. So here's another atypical pattern that's symmetric in each eye. This is another type of pericentral pattern here. And what you'll see on the color of this photo is there are really not a lot of pigment changes. There's no bone spicules, okay? And this is RP due to a gene called HGSNAT. But it can mimic another condition called bilateral annular variant of Azor or syphilitic outer retinopathy, and I'll show you what that looks like. So this is syphilitic outer retinopathy. All right, so if you look at it, it's still got this kind of pericentral pattern. You see on angiography, there's kind of early autofluorescent, sorry, there's vascular leakage as well as leaking CME, okay? That's probably one difference. In Azor, you don't see as much leakage. And in this patient, they were treated with IV penicillin. And the vascular leakage and the leaking CME, initially, it looked like it was getting better, and then it got worse, which can happen in these sorts of cases. And the CME became chronic. I also wanted to show you what it looks like over time. So even after the inflammation becomes well controlled, there can also be a component of progressive degeneration. This is not very well understood. It's possible that these patients, basically develop kind of a chronic posterior occult uveitis that just kind of degenerates. So now here's a case of bilateral annular Azor, right? So also kind of affecting the pericentral area. Now this is very early on what I'm showing you. So on the autofluorescence, you're not really seeing any hypoautofluorescence. In fact, you're seeing hyper autofluorescence in the pericentral area. Okay, and OCT, shows damage to the outer retina. And over time, 6 months, 8 years, you'll see that the affected areas start to pigment, the vessels narrow, and so that starts to look a little bit kind of like that pericentral RP. Right, and you see on autofluorescence, it takes time for the damaged areas to become hypoautofluorescent. In this case, not only is it acute, right, but there is easy recovery as well as stability that occurs over time. So these conditions, Azor can kind of enter this quiescent phase, right? So this kind of dynamic acute change, both in the damage as well as the recovery, as well as the propensity for stability, right? That will help you differentiate between this and RP, because RP is chronic and degenerative, and it doesn't stop, it doesn't recover. All right, so next category is the asymmetric between the two eyes. All right. So this is a patient with unilateral retinitis pigmentosa. Okay, just one eye is affected, and the eye that is affected looks pretty typical. These are pretty rare. There's probably only one published case where it is pretty definitive. There's one case in the literature due to a gene called RP1 where many members of the family have RP, and then suddenly you have one patient, one family member where it's only in one eye. So it can happen. And the differential for this is Azor, right? Azor, even though I showed you a bilateral case, Azor often is in one eye. Duzen, as well as potentially unilateral AR, autoimmune retinopathy, which is also rare. So the final category here is, I think, the most complex type, right? It's different between the two eyes, and within each eye, it just doesn't look typical. So here's a case of X-linked retinitis pigmentosa, and this is a woman, so it's a female carrier state. The gene is RPGR, and you can see that what's happening in the two eyes look asymmetric, and also within each eye, it's really atypical. It affects kind of this area that seemed to emanate from the disc. All right, and this can masquerade as serpiginous choroiditis. Granted, the boundaries of the affected areas are not as tight. You can see that the boundary, it's more diffuse, and it can also mimic chronic CSCR. When you have guttering. So here's another one. Another case of X-linked retinitis pigmentosa, female carrier state. And this one's due to the gene called RP2. So you can see how different it is. This one looks nothing like the other case I showed you, right? It's you see these kind of mid to far peripheral areas, patchy areas that are affected, almost kind of in a radial pattern. All right, so this is the final portion of the masquerade part of the talk. So atypical timing, late onset. So here's a case of a late onset retinitis pigmentosa, and it's due to a gene called HGS-NAT. And we're starting to realize that there are these, we call them hypomorphic variants or mutations that are just not as severe. And that's what happens is we think it's connected to these late onset phenotypes. So this is a patient whom came into my clinic complaining of just 1 year, right? A 73-year-old complaining of 1 year of decline in vision, right? So normally if you hear that, you don't really think genetic, right? You think of something that's acquired. And one of the most common things that you think about is potentially autoimmune retinopathy, right? Or cancer-associated retinopathy. And in this case, that was actually the initial thought. All right. So this patient actually had an autoimmune retinopathy and a uveitis workup, right? And you can see these are the results of that. And you can see positivity on the immunoblots, as well as positivity on immunohistochemistry. So here's another one, another type of late onset. All right, so this is due to a gene called DRAM2, DRAM2. And instead of causing a kind of a RP-like, this is the opposite. It causes a cone rod dystrophy. And again, it occurs late in life. And it can mimic, again, autoimmune retinopathy or cancer-associated retinopathy, which can also produce a kind of a cone rod phenotype. So let me show you a case of non-paraneoplastic autoimmune retinopathy. So this is a 55-year-old with decreased vision for 2 years, right? And you can see here on autofluorescence and OCT, there's kind of this pan-retinal degeneration with residual macular areas. And there is a little bit of asymmetry between the two eyes, and the ERG was flat, unrecordable. Okay, and we send it for autoimmune retinopathy testing. did big workup, uveitis workup was negative, cancer workup was negative. And again, you see positivity, right, on the autoimmune retinopathy test, on the immunoblots, as well as immunohistochemistry. Okay, now in this case, we treated the patient at first with methotrexate, and it didn't really have much of an effect. These are autofluorescent images, and the good areas of the retina are actually the darker areas. Okay, but you can see there's this progression where you just keep losing those good areas. Finally, we started IVIG, and she's now stable, and it's been stable for years. So these are the pearls, right, to try to differentiate between IRDs and autoimmune retinopathy. Because, I got fooled, by that first case that I showed you. And that first case that I showed you, I treated that patient with immunomodulation for several years, until we figured out that the mutations that she had were relevant. This idea of hypomorphic mutations is a evolving area of study. When I first saw her, the gene testing lab called those variants variants of unknown significance, meaning probably not meaningful. And 3 years later, the lab basically revised their interpretation and said, no, okay, now they're hypomorphic mutations. So that will always be challenging. But the one thing that I learned is that the rate of degeneration can really help distinguish these things apart from each other. In inherited retinal degenerations, whether it's late onset or early onset in life, typically you will see change at the 1 to 2 year mark when you follow these patients. So it's pretty slow, right? It doesn't matter if you're looking at visual fields or imaging, but you really won't see much change until you wait 1 or 2 years. But in autoimmune retinopathy, it's typically more rapid. You will see changes over the course of 3 to 6 months. I get everything that I can get when I'm following these patients as far as diagnostics, right? Structural, imaging, autofluorescence, OCT, functional tests, microperimetry, visual fields, full field visual fields, as well as full field ERG. And then treatment, for autoimmune retinopathy, most will agree. You typically do a step-ladder approach. Start with immunomodulators, antimetabolites, and then if that doesn't work, you go to IVIG and rituximab, and then also intravitreal steroids as needed. All right. So next, I'm going to talk about gene therapy associated uveitis. Briefly, I want to just cover the idea of immune deviation. So we know a lot about anterior chamber. So that's anterior chamber associated immune deviation, or ACADE. And it's basically a deviation of the way the immune system works, right? That's the better way to say it. I don't really like as much the term immune privilege, because it suggests that the immune system is naive, and it's not. So in ACADE, anterior chamber associated immune deviation, the eye acts in concert with the systemic immune system to create a form of immune deviation that inhibits type 1 delayed hypersensitivity, inhibits Th1 response and complement antibody responses. In fact, it favors antigen-specific cytotoxic T cell responses, antigen-specific T regulatory cells, and antibodies. There's overlap. So we know similar types of immune deviation occur in the subretinal space. That's important because that's the most common space that we put gene therapy into. One difference is you have the RPE cells, right? And the RPE cells we know also induce immune deviation, induces T regulatory cells. It disarms active T cells and causes the death of active T cells. It secretes anti-inflammatory cytokines such as TGF-beta. We're not so sure there's immune deviation in the intravitreal space or the suprachoroidal space, which are other routes of delivery for gene therapy. So gene therapy most commonly uses AAV, adeno-associated virus. There's a capsid, and then there's a genetic viral genome here. And what we do in gene therapy is we take out parts of the viral genome and replace it with the genetic construct, the gene that we want to deliver. As I said, there's different ways to deliver AAV. We think that subretinal space probably has the least amount of inflammation, whereas other routes of delivery like intravitreal tends to have higher risk for inflammation. So you saw this diagram already. Okay, I'm going to get it to the point where we've got retinal degeneration. Okay, we talked about that already, but now we introduce gene therapy. So the AAV capsid and the AAV DNA and the AAV RNA actually are also recognized by similar elements in microglia, TLR as well as NLRs. And they all compete, all right, go through similar pathways and then basically compete again to activate the microglia, towards potential M1 and M2 phenotype, right? So there's potential for AAV to exacerbate the kind of innate immune reaction that potentially already exists in these degenerations. And so it's no surprising that we do see inflammation. It's quite common to see inflammation after gene therapy. Now, fortunately, most cases are mild, respond to steroid treatment. But there are some cases that become more chronic and severe. So we define gene therapy-associated uveitis as just any inflammation that occurs greater than expected from surgery alone. But it can be variable in terms of severity, location, and duration, right? It can be in the anterior segment, intermediate segment, or the posterior segment, or panuveitis, all segments. It can be limited episode, relapsing, chronic, or recurrent. Okay. There's been good reviews showing that some of the risk factors, probably the strongest risk factors is the dose. So the higher the dose of AAV, the more likely a patient can have uveitis. All right, so we're getting close to 40 minutes now. We're almost done. So inherited uveitis. So this is just the final slide. I'm not going to get into each one of these conditions because it'll be another big talk, but this is something to remember. All right, so these are 5 conditions here, which are inherited forms of inflammation. And I'll just kind of organize your thinking here, right? A lot of these are autosomal dominant. The second one, CAPN5, which causes autosomal dominant neovascular inflammatory vitreal retinopathy. That's the only one on here that's specific to the eye. Okay, all the other ones have systemic manifestations, right? So it's important to remember that. The very one on the bottom, chronic granulomatous disease. So there's actually 2 genes there, NCF and CYBA. That one can also be recessive and X-linked. Okay, so remember these conditions. All right, so in summary, I talked about how photoreceptor cell death and degenerations can trigger a complex immune response, and that this might be why we see clinical signs in IRDs that can be reminiscent of uveitis, but we're not sure what's going on there. Is it a consequence of neurodegeneration? Is there neuroinflammation? Should we be treating these patients with immunosuppression? I showed you how these IRDs can have atypical and asymmetric and late onset presentations, which mimic and masquerade uveitic conditions like azor, more, syphilis, AEPVM, or AIR. Okay, and one of the pearls, I said, when in doubt, establish the rate of degeneration. That can really help you figure out what's going on, right? And then we talked about gene therapy associated uveitis. So if you have a patient with a known diagnosis of retinal degeneration and they have uveitis, even though it's still pretty rare for a patient to have had gene therapy, it's important to ask about it. And then finally, we just went over briefly inherited causes of uveitis. So thanks again for inviting me to talk. These are complex topics, but I'm very happy to talk about it. These are the kinds of patients that tend to end up in my clinic. So happy to take any questions.
So, Dr. Poe, thank you very much for this enlightening talk. Thank you again for taking your time to share with us your knowledge. And does anyone would like to ask a question, Dr. Poe?
I would like to thank you once more, Paul, to be here with us. And I think the younger fellows didn't know that many of our fellows, like Mariana Valim Salles, Mariana Maccioli, Uber, and two other past students had spent some time doing a fellowship at KCI. So it's really a great place, and you really make a difference in the field of RDs. So from the cases that you present, we can figure that. And having a clinic that has not our RDs, but also inflammatory diseases, that's really even trickier. I think that's a difficult part of the RD field, when you end up with a patient that might have like autoimmune disease, or and Casey has a lab that has this kind of test. Can you comment if you use the test for autoimmune retinopathies? Can you bring this information to the team?
Yeah, thanks, Juliana. It's always a pleasure. And so, all the fellows that trained here and went back, I'm sure, they have personally seen some of these cases, and they know what firsthand how difficult it can be to tease these apart. As far as the autoimmune retinopathy panel, I think I've illustrated that it can be a little bit confusing if you get the panel too early on in the process of the workup, because you can see that it was positive in one of the cases where it was a late onset retinal degeneration masquerading as autoimmune retinopathy, as well as being positive in the case that I told you was non-paraneoplastic autoimmune retinopathy. So I think that's the problem. Is I think the autoimmune retinopathy test is not very specific, right? It's perhaps even too sensitive. So I get the autoimmune retinopathy test only after I have done everything else, right? I've done the rest of the typical workup, which may include uveitis workup, genetic testing, and then following the patient too, right, to establish the rate of change. And so only when I am convinced that this is possibly autoimmune retinopathy, then I get the test, so that it's supportive before I begin treatments. I think if the test comes back negative, again, there's no big study, but that's just my clinical impression. If the test comes back negative on the immunoblot and negative on the immunohistochemistry, I think that's probably more meaningful. Then that means that it probably cannot be autoimmune retinopathy, because I feel like that is the very definition of autoimmune retinopathy, right? It's there's the presence of these autoantibodies. So if it's negative, then I have to change my thinking, and I may not treat. So I may go in a different direction if it comes back negative.
Thank you. It's really a negative sometimes helps us better than the positive because yeah.
I have to say though that I have several cases where they were negative. They continue to be a mystery, and I monitor them over the years. And then they come back with a change in the rate of degeneration. They start to have more rapid change, one eye, or an acute episode, and then they slowly start to convert, meaning that their autoimmune retinopathy test goes from negative to positive. So some of these cases actually change before my eyes, and then they become autoimmune retinopathy.
Dr. Paul, do you have any specific antibodies that you look with special care, like anti-recovery, anti-analase, or do they the kind of antibody is important to diagnose? What do you think?
That's a great point. I think recoverant is probably the most specific. I think if you see anti-recoverant, it is probably a case of either non-paraneoplastic or paraneoplastic. Typically we see recoverant related to small cell lung cancer, but you can also have non-paraneoplastic anti-recoverant. That's probably it. Beyond that, the second antibody in which we have more data on is enolase. So anti-enolase antibodies tend to be associated with kind of obstetric type cancers and tend to cause macular and cone type of degeneration. But the problem is that there's also it's also probably too sensitive, right? You can pick up anti-enolase antibodies in patients with retinal degenerations or even just normal controls. And the problem is this, we all have antibodies to different proteins and antigens. And there's a difference between pathogenic antibodies and benign, autoantibodies. They bind to different parts of the protein. And so it's known that the pathogenic antibodies and benign antibodies have different epitopes, basically preferred binding areas on a specific protein such as enolase. We don't quite know why normal controls have benign antibodies, but if you can test the different epitopes, you can distinguish between the antibodies that would cause autoimmune retinopathy and the ones that just exist in everyone else. So Groznia Adamus, she directs the autoimmune retinopathy lab here. She's done a lot of this work to show that. Now, the only problem is, unfortunately, that hasn't translated to the clinical test, right? The immunoblots that I showed you. So those immunoblots don't tell you whether it's pathogenic or benign epitopes.
Kaya, do you have a question?
Yes, thank you, Dr. Yang, for your talks. Very impressive. And considering the advances in genetic therapies for retinal diseases, do you foresee the integration of gene technologies such as CRISPR with immunological strategies to enhance the therapy?
So that's a good point. There is now an industry standard for immunosuppressing patients undergoing gene therapy perioperatively. So usually it's some combination of topical and systemic steroids, perhaps also subtenon steroids. And the coverage is usually starting days before gene therapy to anywhere from 3 to 6 weeks after gene therapy. Now, fortunately, like I said, in most cases, that's sufficient. And you don't really see a lot of inflammation when that sort of immunosuppressive coverage is implemented. But then we have patients that have breakthrough inflammation when you start tapering the steroids. That's the extent. There is no industry standard for using immunomodulators like antimetabolites or other things just yet. And I think it's because, fortunately, there's just not a lot of cases of chronic or recurrent gene therapy associated uveitis. I've certainly seen my fair share, but as far as looking at the total picture, fortunately, there aren't a lot of those patients. So I think currently it probably doesn't make sense to put all the patients on immunomodulation unless they're going to develop chronic or recurrent inflammation.
Juliana?
Me again, let's take profit of your presence here. From our 6 patients with gene therapy for Luxturna, we already have some mild inflammation that we could control like in the 1 month post-op. And then we increase the corticosteroid, and then you end up with glaucoma, and then it takes a little bit of extra time to control the glaucoma. So it's tricky, the post-op for a gene therapy surgery. But my question for you is, from all the gene therapies that you have contact at Casey, because you were site for all the clinical trials in gene therapy, is there one that is more inflammatory than the others?
Yeah, so thanks for asking that question, Juliana. I think I alluded to intravitreal delivery being more inflammatory. And so I can speak freely about this one because we published it already. So this is delivering the RS1 gene intravitreally for a condition called X-linked retinoschisis. And I think because it was delivered intravitreally, you're basically putting the load of viral genomes and viral capsid right into the vitreous space, which I already said, I don't think has much of a immune deviation. We saw a higher rate of inflammation that was unmasked when you tapered the steroids. And in fact, 3 of the patients in that study went on to have chronic vitritis, chronic keratotic precipitates, and I had to immunomodulate those patients. I started with methotrexate, and I was able to get one of them into remission, and that patient is now off treatment and in remission. Unfortunately, the other 2 patients are, after a year of treatment, they became lost to follow-up because that was right when the pandemic started. So I don't really know what's happening with one of them that was lost to follow-up. The other one finally came back after being off treatment. He decided to not do treatment because at the beginning of the pandemic, I think everyone was scared about COVID and weren't really sure what it would mean to be on immunosuppression. But that patient came back to me 2 years later with no treatment and had dense vitritis and dense vitreous debris and had a lot of vision loss because of that. So, I had to get that patient on treatment again, lots of steroids to clear the vitreous debris, and finally got the vision back, but then he developed cataract. So now he needs cataract surgery. And then after that, I have to determine, what to do next. I think for that patient, we may actually consider a vitrectomy because I think if there's still viral capsid and antigens in the vitreous space, he's always going to keep mounting an immune reaction. There's some studies in animals showing that microglia and macrophages can go to the vitreous space or even the iris and stay there and become chronic and become a nidus for inflammation.
No patients think on the risk they take as much as we can explain to them prior to the surgery that is not a easy PET, that's a post-op, it's a viral vector that we are including in the eye. So it's really tricky, and really you have a team very prepared to take care of this, because it really brings complications to the field. So congratulations to handle this, because it's really hard. It was a pity that the retinoschizis trial didn't went through, but congratulations. Thank you for answering.
Yeah, you're welcome. On the bright side, Juliana, this was presented at Arvo, but at Cena, a different company that's now developing gene therapy for X-linked retinoschisis. They showed the results of the first 3 patients, and this is a different vector, right? Different company, but it's the same gene. It's being delivered subretinally with a vector that spreads. And they're showing there's not a lot of inflammation, and looks like it's potentially effective in collapsing the cysts. So I think in the field, we are making progress, right? With kind of second generation AAVs that are more sophisticated, and different routes of delivery, right? I think we learned that intravitreal may not be so effective, right? And in fact, it can be inflammatory. So I think more companies are gravitating towards subretinal delivery.
As images were really impressive. It dry out all the spaces in the cases, really impressive. So it brings a lot of hope back to the retinoschizis patients. Again.
Well, does anyone have any other questions to Dr. Young? Okay, so thank you very much again, Dr. Young, for this excellent talk. We're now going to have our clinical cases. I feel you're free to stay with us, but I know you have a busy schedule, and hopefully you'll come back other time to share your enormous knowledge about uveitis and genetics, and was very, very helpful to think about differentials. We will always have sometimes in our lives, we're going to have those cases, and it really helps us to guide what to think about or how to manage and follow those patients. Thank you once again.
You're welcome, and thanks again for the invitation.
Então, acho que podemos começar pro primeiro caso, né? Se puder, acho que talvez apresentar em inglês, continuar.
All right, well, thank you, and have a good day. Bye-bye.
Thank you.
Bye-bye, thank you.
Bye.
Vocês se deram bem aí, hein? Bom, já que vocês prepararam em inglês, pode apresentar em inglês.
Tá certo aí, professor?
Tá certo, dá para ver.
Eu vou apresentar em inglês, que é o meu grand round da semana que vem. Tá certinho
Manda
aí?
bala.
Perfeito. So good morning, everyone. My name is Mateus. I'm a second year resident here in the service, and I'm going to present my grand round case today in this meeting. My preceptor was Dr. Fernando Marlebi, and the head of the division is Dr. Kaya. I'm going to present a case that was previously presented at this meeting to discuss the management, and now I'm going to present as a grand round with the exams and final tests. and the follow-up as well. So our case is about a 33-year-old male patient, white, born and raised in São Paulo, that was referred for our retina department from the emergency room, complaining about sudden low visual acuity in the left eye 7 days before. He reports lipothermia on the same day as the onset of the condition with fast recovery of conscientiousness. He denied any history of trauma as well. He denied any past medical history and past ophthalmological history. And about medications, he denies, only mentions the use of supplements as whey protein and creatine. And he denies smoking and alcohol consumption. About his ophthalmological exam, his best visual acuity in the right eye was 20/20, in the left eye was hand movement. And I'm going to show photos of the anterior by microscopy. His intraocular pressure in the right eye was 14, in the left eye it was 12. And I'm going to show photos of the endoscopy as well. Here's the anterior by microscopy. I don't know if any resident wants to comment.
On the right eye, we have a clear conjunctiva, clear cornea, deep anterior chamber, traffic iris, and phakic.
And here in the left eye is very similar, but the patient is in pharmacological mydriasis, a normal exam. And the endoscopy of the right eye.
And we have a pink optic disc with sharp margins, normal vessels, normal macula, and attached retina. On the left eye, we have optic disc with unclear margins, diffuse retinal pallor, a cherry macula, and attached retina.
Perfect. And in this image, we don't see a Hollenhorst plaque.
There's also a macro vessel.
Yes.
Yeah. And you have the very small ciliary artery, a patent ciliary artery that is very small.
Mateus, do you know what is the macro vessel?
Yes.
Can you show?
Yes. It's right here.
No. The macro vessel is down. Is the vessel that is down, that goes to the fovea.
Oh, right here?
Yes. So this branch.
Okay.
I think that there is also around the disc a axoplasmic blockage. Not only disc edema, there is some blockage, axoplasmic blockage, because you see some accumulation of some white material around the disc. Do you agree?
Always.
Okay, can you see what I'm saying?
Yes.
Okay.
So for diagnostic hypothesis in front of a patient, our main hypothesis was a central retinal artery occlusion. And so in front of a patient with central vein artery occlusion, we will think about some groups of causes. First one is atherosclerosis and embolism that could be secondary to vascular heart disease or arrhythmias or carotid stenosis. The second group is hematological causes like thrombophilias or myeloproliferative disease. Sickle cell anemia and inflammatory causes is the third group that we would think about some vasculitis like BC or lupus. And we will think about as well other causes like use of medications or Sussac syndrome. So for the management of the patient, it's important to refer the patient for the systemic evaluation as it was a urgency. We would perform retina assessment, multimodal retina assessment like OCT and geography, fluorescein and geography. And we would do complementary tests like blood count, coagulogram, lipid profile, inflammatory and rheumatological tests, carotid Doppler, electrocardiogram, and hemoglobin electrophoresis. And we could perform some aerobic measures that we are going to talk about forward. But he was referred for our service 7 days before the low vision occurred. And so in the autofluorescence exam, I don't know if we have to stop some
Okay,
more.
so in the fundus autofluorescence of the right eye, we have a normal exam. In the fundus autofluorescence of the left eye, we have this diffuse hyper autofluorescence in the posterior pole. Yeah.
And also here on the left eye, usually the optic nerve is hypoautofluorescence, and here you can see the hyper autofluorescence on the optic nerve due to the edema and, as Professor Michel said, oxoplasmic blockage.
So for the OCT of the right eye, we can see a normal vitreous retinal surface, unpreserved foveal depression, no alterations in the inner and outer layers of the retina, and normal choriocapillae. It seems to be a normal exam. And for the OCT of the left eye, we can see this irregular retinal surface with this disorganization of and thickening of the inner and outer layers of the retina, and it's difficult to evaluate properly the outer retina. I think it's that.
So here's the fluorescence and geography of the right eye. It's a normal examination. It's normal one. So here's then the left eye.
So the fluorescence and geography of the left eye, we have this central hypofluorescence, which is compatible with poor perfusion. Yeah.
Okay. So we performed some blood test examinations for the patient. We performed blood counting. It was normal one, normal hematocrit, normal hemoglobin, normal leukocytes, and normal platelets. It was negatives for serologies as VDRL and HIV. Blood glucose was normal either. Urea and creatine, it was a little bit upper the normal limit, and sodium and potassium was normal either. C protein reactivity was lower than 0.6. Prothrombin time, INR, and activated partial thromboplastin time was normal either. And we performed a protein electrophoresis and rheumatological factor and antinuclear factor that was non-reactive. We performed either some cardiological exams. The electrocardiogram was normal, and the carotid Doppler ultrasound was normal. And about his transthoracic echocardiogram, it has a mild regurgitation of mid-mitral valve, and we had an interconsultation with cardiology team, and in which they said that it was a mild, kind of moderate mitral stenosis, but without surgical indication, and would not likely cause this condition of arterial occlusion just by this cause, just by stenosis, and they recommended us to looking for secondary causes and starting probably anticoagulation, but they would follow the patient in this time. together with us. And so back to the case, we call the patient again to ask some important things about the anamnesis and to show the results of the exams. And the patient report unuse of anabolic steroids. He used nandrolone decanoate and testosterone esters in December 2023 for 45 days was a cycle. He denied any use of illicit drugs like cocaine. And at the time of the incidents, he was using either thermogenics and supplements for muscles hypertrophy, as I said in the beginning of the case. Here I showed pictures of the exact product that he was using. So in accordance with this story and with the normal blood counting and cardiology tests in a young patient with central artery occlusion, and the literature reviews that we performed, we had the diagnosis hypothesis of a central retina occlusion secondary to anabolic steroids. And we follow up the patients 2 months after the beginning. And his best corrected visual acuity was the same. In the right eye, 20/20. In the left eye, it was hand movement. No alterations in the anterior by microscopy. The intraocular pressure was 13 in both eyes. I'm going to show pictures of the fundoscopy of the left eye, and we performed either a gonioscopy that was with open angle up to sclerospore without synechias and without angle vessels. So here the fundoscopy of the left eye after 2 months of the beginning, and we can see temporal pallor here of the optic disc. We can see either pallor in the posterior pole. You can see this well-definite lesion affecting the foveal area with dark appearance and with yellowish dots in the middle that could correspond to exudates or tissue disorganization. And we could see there a good perfusion in peripheral areas. And so here's the autofluorescence after 2 months. So here we can see this foveal lesion with appears that is a turning hyper and hypo autofluorescence. And here's the OCT after 2 months that we can see this wide-net foveal depression, foveal thinning, and loss of the layers parallelisms. And we can see the disorganization of inter and outer layers. And we can see these cysts that are parafoveal space that could be degeneratives.
I think an advice gift for you is to write a report for the patient that his case has been discussed and that was our conclusion. Imagine that you are in a clinic and you receive this patient years ahead, and we will never figure what has happened to him. So I think it's important to not only explain to them, because not always they understand and remember later, but give something written of what was our conclusion. And also comment on the vessel, the macrovessel. A clue is a macrovessel usually across the median. We saw in Portuguese half. I don't know if it's English also half. It goes to the other side of the retina, so it is burning down in the inferior area, and it crosses to the superior area too. So that's a clue for this vessel.
Thank you. So here's the OCT angiograph that we can see the enlargement of the fovea avascular zone, but no other signals. And here's the fluorescein angiography of the left eye that we can see kind of signs of hyperfusion, and we can see the same macular fluorescence due to, as Henrique said, could be a poor perfusion.
Mateus, here in these exams, it's important to put the time of
Yes.
after infusion, because usually you have a delay on the timing. Okay, so just put a time here in this slide.
Okay. Thank you. And so we performed a literature review, and we found 2 case reports that talks about the same topic, central retinal artery occlusion patients that are bodybuilder. And we found 2 articles. The first one was in Polish, and the second one it was in Brazil, in Rio. And the first one talked about just 1 case, and the second one talks about 2 case reports. And the second case of the second article is very similar with our case. I'm going to explain you why. But both of the articles agrees that with the use of anabolics that we could increase the production of clotting factors that could cause a hypercoagulant state and either cause an impair endothelial function, causing a vascular dystrophy and development of arteriosclerosis. Either in a long-term effect, it could cause increases cardiac output as hypertension and could change the lipoprotein metabolism, causing hypercholesterolemia and hypertriglyceridemia. And it could increase at all the risk of thromboembolic events. And in the second article, one of the patients were using diuretics together with these medications, and the article he states that can also increase the blood viscosity, but our patient was not using diuretics in this time. And either we found an article that we're talking about a case of a pulmonary thromboembolism, probably associated with the use of creatine supplement. And the patient in this case had no history of thromboembolism and other causes, and other causes of thrombophilia were unlikely to this case, and they believe that it was due to the creatine use that he was doing, and the patient of this case ingested more than it was recommended. So what the article said that the creatine supplements like promoted dehydration during intense workout and profuse sweating. And dehydration is no risk factors for these causes of thromboembolism, and it increased blood viscosity. We didn't find articles that were talking about use of creatine and related to ophthalmological causes of occlusion, but it could be a risk, as the article said, and our patient were doing use of these kinds of medications. And here we are going to see some heroic ocular measures that could be done in the beginning of the patient in this case.
Matheus, deixa eu só perguntar uma coisa. Esse caso é do Greyhound?
Isso.
Tá longo demais. Tá muito longo. Nós vamos ter que cortar um monte de coisa. Tá muito longo, tá? Eu não sei... Não, o caso tá lindo, é um caso lindo, a gente viu na triagem, eu sei disso, tá maravilhoso, mas nós vamos ter que enxugar, porque tá muito longo. Nós vamos estourar os 15 minutos e aí não vai tomar tempo nenhum para a gente discutir. E é super importante esses pontos, né? A Juliana comentou um ponto, o Caio comentou 2 pontos, então a gente vai ter que dar uma enxugada, viu? Porque está muito longo.
Perfeito, professor.
Mas continua aí.
Tá no fim já, falando 2 slides só. So for the heroic ocular measures, we could perform eye massage or anterior chamber paracentesis or either reduce of intraocular pressures. All these measures would try to remove and move the embolus to another area and try to recover the perfusion. Other measures is increase carbon dioxide concentration that would induce vasodilatation and try to move as well the embolus. And there are another one that it's intravenous TPA that are not a good option, and it has a lot of many adverse effects as article Eagle cites. So as take-home message of this case, it's very important to have a good anamnesis of all the cases. It's important to know the lifestyle habits, the use of medication of the patient's risk factors. In the first meeting that we have with the patient didn't told us about the use of anabolics and other kinds of medications. The second one is to adequate a laboratory and systemic investigation of the patient is very important in cases like this. And a multifactorial approach with the cardiological team is either important. And third one is to treat central retina artery occlusion as a medical emergency and not just ophthalmologic ones. And as we saw, we have just little evidence-specific treatments in the acute beginning of the setting and improvement in visual acuity. It's not in evidence. So that's it.
Na hora que você falou os exames, você acabou falando todos os exames, então todos normais, né? Então, naquele slide dos exames, deixa o slide do jeito que tá, mas fala que todos os exames clínicos são normais, tá? Porque você foi falando exame por exame, então eu acho que coloca que todos os exames esses exames foram realizados, são todos normais, entendeu? Aí você já ganha 2 minutos quase. Mas eu acho que poderia.
Enxugar também, estou orientando aqui o Matheus nesse caso, né? Fernando Malherbe aqui falando. A gente viu esse achado de eco transtorácico que tinha algum achado e a gente foi interpretar com a cardio se isso era relevante para o caso ou não. E aparentemente não é relevante, né? Os achados que o TECO trouxe. Então, talvez resumir também esse slide, dizendo que ele foi feito a avaliação cardiológica com ecocardiograma, Doppler de carótida e transtorácico, que não revelaram informações relevantes e que ele está sendo acompanhado com a cardio. É uma outra sugestão para tentar enxugar um pouquinho também.
Muito bom. E mesmo nas imagens, Fernando, às vezes a gente põe o importante que o Caio falou de ter o tempo para ver o delay, né? E põe menos fotos, né?
Isso.
Não precisa tanto, não precisa nem tanta periferia. Para a gente dar tempo de eu te chamar para discutir isso. É um caso bem interessante, né? Tem um monte de residentes bombados no nosso arsenal de quem presta atenção no Greyhound. Então, é um baita caso interessante e muito relevante. Então, a gente tem que dar só uma enxugada para você comentar esses pontos mais interessantes, entendeu?
Perfeito.
E dá tempo de eu chamar o Caio para fazer o fechamento do caso, tá bom?
Ótimo.
E no final, eu acho que dá uma resumida nessa parte final do resumo. Acho que só colocar acho que é importante colocar esses artigos, mas só citar que tem esses artigos e as medidas, falar que existem as medidas, mas tem tempo dependente e não ficar. Eu acho que essa parte acaba sendo suplementar, né? Então essa rapidez. E no dia também, você acha que se apresenta um pouquinho mais rápido, aí o tempo economiza também.
Tá bom. Obrigado, professor.
Mas vocês sabem que eu gosto desse tipo de caso para Greyhound, né? Eu acho que é bem enriquecedor para a plateia que a gente tem, né, no Greyhound.
A Marina perguntou se fechou com o uso de creatina.
Fechou como
Não
uso de antes mesmo, mas a gente viu que creatina também tem uma relação não na oclusão de artéria ou de veia central da retina, mas tem uma relação com tromboembolismo pulmonar. Então, isso também aumentou o risco do paciente, mas não é não ficou como diagnóstico dele.
Talvez uma soma, né? A desidratação, a creatina, o termogênico que pode dar vasoconstrição, aquele uso de esteroide prévio, tudo isso junto aí, né?
Se tivesse desidratação assim, mais crônica, não ia aparecer no exame de ureia, uma ureia elevada, creatina elevada. Estava no limite, obrigada.
Tem, tem hematócrito?
Tem.
Não. 43, né?
Parabéns, Matheus, muito legal mesmo.
É
Vai
isso que
criar
isso
alguns.
que a Lu está comentando aqui no chat é verdade. Esses pacientes tomam um excesso de proteína também, que às vezes daí pode aumentar a viscosidade, né? Então, acho que é um ponto também que contribuiu.
Tinha proteína no plasma?
Olha, no fisiculturismo também o pessoal toma bastante diurético, você comentou isso, né? Toma diurético para secar e definir, principalmente pré-competição. No dia anterior à competição, não toma água e toma diurético. Aumenta a viscosidade, né? Também.
Na revisão de literatura, a gente até viu um caso que foi secundário a um paciente que fez exatamente isso. Ele estava fazendo uma maratona, usando diuréticos, usando outras causas e fez a oclusão, mas não tinha associação com anabolismo.
Essa questão do diurético que o Michel coloca é importante, né?
Maravilha. Então dá uma enxugada aí, Matheus, vê com uma lerbe o que dá para fazer
Dá uma
aí.
enxugada sem diurético.
Sem diurético, sem bomba.
Isso aí.
Qualquer coisa, se qualquer dúvida, a gente pode chamar meu amigo Paulo Musi, que é da minha turma da escola.
Cintura?
Paulinho Cintura. Quem que é o próximo que vai apresentar?
Professor, sou eu o próximo a apresentar. O caso está pronto em inglês e em português.
Apresenta em inglês, falando em inglês, por favor.
Ok. So, good morning, everyone. My name is Henrique Ferrer. I'm a second year resident here at Escola Paulista de Medicina. And
Pode,
they have...
compartilhe a tela primeiro, por favor.
Oh, sorry. Mal, professor.
Mas não tem ninguém na lista de presentes que fala inglês, né? Por que que a gente está... É para exercício de inglês mesmo?
Eu tô brincando com ele, porque eles prepararam porque caso o Paul Young ficasse na reunião. Não, mas pode apresentar em português, vai.
Obrigado, professor. Vamos lá. Então, meu nome é Henrique Ferrer, vou apresentar o caso clínico aqui na reunião do setor. O chefe é o Dr. Caio Regatieri. E a gente tem uma paciente do sexo feminino, de 58 anos, parda, natural procedente de São Paulo, que refere baixa acuidade visual no olho esquerdo há 4 dias e uma baixa de visão no olho direito já há mais de 5 anos. Ela não sabe precisar exatamente o tempo e negava qualquer dor associada e outras queixas visuais. Ela tinha, lembrando aqui, uma paciente de 58 anos, que já tinha um diagnóstico precoce de Parkinson aos 41 anos de idade, estava em uso de bromazepam, carbegolina, donepezilã, levodopa e razagilina. Negava outras comorbidades clínicas e outros antecedentes oftalmológicos. A acuidade visual era de percepção luminosa no olho direito e conta-dedos anteface no olho esquerdo, e a biomicroscopia anterior do olho direito, ela tinha cílios e pálpebras sem alterações, conjuntiva clara, córnea transparente, a câmara anterior formada sem reação de câmara anterior, a íris trófica e fáscica. No olho esquerdo também, a biomicroscopia anterior sem alterações. A pressão intraocular era de 15 em ambos os olhos, e a fundoscopia eu vou mostrar fotos. Algum R1?
Bom dia, meu nome é Cindy Sorril. Então, no fundo de olho do olho direito tem um disco pálido, bem delimitado. Os vasos estão normais, parece ter uma atenuação nos vasos. E tem uma lesão hiperpigmentada na região da mácula e a retina está aplicada.
Isso, muito bem. Os vasos estão atenuados e a gente atenta aí essa lesão hiperpigmentada na região macular. Assim, olho esquerdo.
Então, no olho esquerdo tem um disco, parece pálido também, as bordas estão mal delimitadas, um pouco borradas. Os vasos estão tortuosos, aumento de tortuosidade. Parece que tem uma dilatação venosa também. Tem uns exudatos algodonosos peridisco, umas hemorragias intraretinianas, seguindo as arcadas aqui mais temporal. Mácula parece estar sem alterações, a retina está aplicada.
O disco tá borrado, né? Mas não diria pálido, tá? Mas no mais, a gente tem esse engurgitamento vascular, essas hemorragias, as manchas algodonosas peridisco. Muito bom. E aqui?
Então, aqui na parte superior tem uma lesão hiperpigmentada, um centro mais amarelado, atrofiado.
Você consegue perceber a topografia aqui? É uma topografia que parece subretiniana, tá? Bom, aqui na autoflor do olho direito,
Então, na autoflor do olho direito, tem essa lesão hipoautofluorescente, que corresponde àquela lesão que a gente tinha visto. E também ao redor da mácula tem várias lesões hipoautofluorescentes, associadas também com lesões hiperautofluorescentes.
perfeito. A gente tem algumas áreas, né, na arcada temporal inferior também, áreas de autofluorescência. Aqui, autoflor do olho esquerdo.
Então, no olho esquerdo, aquela lesão superior ao disco é uma lesão hipoautofluorescente e tem também as hemorragias, né, que tem um padrão hipoautofluorescente também por bloqueio.
Perfeito. Então, agora para hipóteses diagnósticas, né, a gente questionou se teria uma oclusão de veia central prévia no olho direito, com uma lesão hiperpigmentada na região perifoveal, que poderia corresponder a um hematoma, uma hiperplasia do epitélio pigmentar da retina. E no olho esquerdo, a gente questionou uma oclusão de veia central também com um impêndio. Então, como condutas iniciais, a gente solicitou um OCT e uma angiofluorescinografia, além de exames laboratoriais gerais. Em relação ao OCT do olho direito, R3,
No ACT do olho direito, a gente consegue ver essa linha de hiperrefletividade aqui na interface vitro-retiniana, que pode corresponder a uma membrana epirretiniana. A gente consegue ver uma superfície retiniana irregular, com atrofia das camadas internas e externas da retina. A gente vê uma atenuação aqui da depressão foveal. Essa área mais nasal aqui, hiporrefletiva, que parece corresponder a alguns cistos intrarretinianos também.
perfeito.
Quando passa, então, quando faz o corte naquela lesão que a gente viu, aquela lesão hiperpigmentada, a gente consegue ver essa lesão hiperrefletiva na camada interna da retina, que parece causar essa sombra posterior também.
Olho esquerdo,
Já no ACT do olho esquerdo, a gente consegue ver interface vitro-retiniana aparentemente sem alterações. Ela apresenta essas áreas hiporrefletivas intrarretinianas, que podem corresponder a líquido intrarretiniana, mas apresenta também essa área hiporrefletiva subretiniana, correspondendo a líquido subretiniano também.
muito obrigado. Bom, em relação à angiofluorescinografia do olho direito, vou mostrar as imagens uma de cada vez, depois colocar todas juntas, né? Primeiro aqui com 31 segundos. A gente tem uma área superior ao disco, né, que está hiperfluorescente, que parece aumentar com o passar do exame. Além disso, a gente tem uma área que além de aparentar aumentar com o exame, parece ter uma área de vazamento. Em relação à região macular, tem uma área hiperfluorescente, né, que parece ter um defeito em janela, uma área central que parece ter um defeito por bloqueio, que a gente consegue visualizar aqui. Além disso, a gente tem também uma aparente hipoperfusão, né, na periferia da retina. Em relação à angiofluorescinografia do olho esquerdo, também vou mostrar as imagens. A gente tem essa área próxima ao disco, né, com defeito por bloqueio, e algumas áreas hiperfluorescentes ao redor dos vasos que parecem ter um aspecto de impregnação. E não parece ter na periferia áreas de hipoperfusão. Em relação aos exames laboratoriais, hemoglobina de 12, leucócitos de 18.000, plaquetas de 260.000, ureia e creatinina sem alterações, as enzimas hepáticas também, coagulograma também sem alterações relevantes, algumas sorologias negativas, mas o que nos chamou a atenção foi um VDRL com titulação de 1:1 com FTBS reagente, e a paciente não referia nenhum tratamento prévio para sífilis. Então, em relação à conduta, nesse caso, a gente tem essa suspeita de oclusão de veia central prévia no olho direito, com essa lesão hiperpigmentada perifoveal. Então, a gente questiona aqui se valeria a pena ou não fazer uma fotocoagulação. E no olho esquerdo, que tem o edema macular, então a conduta em relação ao uso dos antiangiogênicos, e aí, trouxe casos para discussão também em relação à questão desses testes, dessas sorologias positivas para sífilis, né? Se a gente vai iniciar um tratamento para isso. Gostaria de ouvir a opinião dos chefes.
Não, primeiro a gente tem que discutir o diagnóstico, né? Eu acho que é uma paciente de 56 anos que tem Parkinson desde os 41 anos. Então, para mim, isso daí já soa algo estranho, né? Então, aquela máxima da medicina que a gente tem que juntar tudo no mesmo diagnóstico eu acho que primeiro a gente tem que pensar nisso. E ela está sendo acompanhada pela neuro na escola ou é fora? De onde surgiu esse
Externo, professor. Vou
E
passar aqui
outra coisa, Parkinson, vocês viram algum relatório, alguma coisa? Porque Parkinson a gente usa L-Dopa, né? E ela não estava usando benzodiazepínico, bromazepam, carbegolina. Ah, não, ela está usando levodopa. Está usando levodopa.
Tá.
Então, esse bromazepam, carbegolina, acho que não sei, eu acho que é estranho esse diagnóstico. Para a gente tentar associar tudo no mesmo balaio, né?
Sim.
Então, não sei o que vocês imaginam aí de pós-diagnóstica. Eu acho que ela realmente tem uma sequela de oclusão, oclusão de veia central, mas essa questão do VDRL positivo, será que não pode ser um falso positivo?
Pode ser, talvez repetir esse exame.
E essa outra questão também que o Pedro levantou, será que ela não tem uma neurosífilis antiga causando toda essa questão, toda essa sintomatologia de Parkinson aí, entre aspas, né? Então, acho que a gente tem que juntar. Quando eu era R1, até foi no ambulatório da Juliana Salum, eu atendi uma paciente que eu acompanhei, que acompanha a família até hoje. E a paciente veio para ver retinose pigmentar, avaliação de retinose pigmentar. E a paciente tinha feito já uma nefrectomia, porque ela tinha rim policístico, ela tinha um certo retardo mental, já tinha feito cirurgia ortopédica, e ninguém tinha suspeitado que ela poderia ter uma síndrome de Bardet-Biedl. E a gente que fez o diagnóstico dela e a família inteira dela era consanguínea, vários casamentos consanguíneos e vários indivíduos com Bardet-Biedl, né? E eu já tinha passado por diversas outras especialidades e ninguém tinha pensado. Então, a gente pegar esse caso aí e ver uma paciente que foi feito um diagnóstico de Parkinson aos 41 anos, eu acho que é meio, pelo menos a gente tem, pode ser, até pode ser, mas eu acho que a gente tem que levantar uma, um ponto de interrogação. Não sei o que o Pira acha, a doutora Nilva.
Então, o olho direito, ela tem um quadro que não parece só de uma oclusão de veia central, né? Porque tem uma retina destruída, né? Parece que teve um quadro arterial associado. Pode ter tido um quadro arterial.
Entendi.
Tá toda
É.
essa alteração de EPR, de a retina com necrose, né? Toda essa, enfim, não é comum em oclusão da veia central você cursar com essa destruição da retina artificial, alteração de EPR tão grave assim. Então, deve
Por
ter
isso
tido
que
mais.
a hipótese de uveíte aí sequelar é uma boa, né, Rodrigo?
Sim, pode ser. Eu acho que falaram aí, pedir a avaliação da neuro, talvez fazer um líquor, né? Pode estar associado, né? E ele também nunca tratou, apesar que às vezes antibiótico que toma aí trata, né? Pode ser só uma cicatriz, tem um FTABS, um título bem baixo, né? Mas acho que valeria uma avaliação da neuro, ver esse quadro neurológico, se pode estar associado com a CIS, fazer um líquor, né? Também ajudar. E no olho esquerdo ela tem então uma oclusão aí da veia central, com edema, tem parece PAN associado, né? Tem mancha algodonosa. Ah, eu trataria com anti-VEGF esse olho aqui. Eu não sei também se ela não fez uma neurite ótica, começou a fazer uma neurite ótica também nesse olho. Então, um quadro oclusivo meio estranho, né? Para dar aquela sequela do direito e esse quadro do esquerdo aqui. E faria uma avaliação da neuro para discutir a possibilidade de tratar a sífilis. Não sei o que vocês acham.
Aproveitar que a Lu está na reunião, se ela puder comentar, se ela acha que isso daí pode ser uma neurosífilis antiga e que causou essa sintomatologia de Parkinson.
Gente, desculpa, eu perdi. Como que é o perfil dela, sorológico, para a Luiz?
Ela tem um VDRL de 1 para 1, professora, e um treponêmico positivo. Nega tratamento prévio.
Qual a idade dela?
Ela tem
Jovem, né?
58 anos. 58 anos com um
E ela,
diagnóstico de Parkinson desde os 41, em uso dessas medicações.
É assim, é aquele perfil que a gente sempre fica na dúvida, né? Porque eu não sei se eu acredito muito nesses casos de sífilis ocular com VD tão baixo ou VD negativo, né? Só com treponêmico positivo, porque ao longo da vida, quase todos nós, em algum momento, usamos uma azitromicina, uma doxy, uma penicilina. Então, eu acredito mais numa luz tratada, mas como a gente não tem essa certeza, eu acho que é sempre prudente tratar. E aí, nesses casos, se é que é sífilis, a gente tem que pensar que é uma sífilis realmente mais tardia. Esse conceito da neurosífilis e sífilis terciária, a gente tem que ter muito em mente que são coisas diferentes, né? Neurosífilis pode acontecer em todas as fases, não necessariamente isso é igual à sífilis terciária, que são aquelas formas muito graves, que é a tabes dorsalis, que é aquelas formas que a gente hoje em dia nem vê mais. Eu não sei, eu acho que eu vi tabes dorsalis na minha faculdade. Então, é raro realmente a gente ter sífilis terciária hoje em dia por conta de tratamentos que a gente faz ao longo da vida. Eu não conheço descrição de parkinsonismo ou Parkinson associado a sífilis. Não saberia dizer, mas assim, respondendo, eu acho que tem que tratar mesmo, a gente não tendo essa resposta. Mas bem interessante, porque as manifestações oculares são compatíveis, né, com um quadro de sífilis. Se ela não tem conhecimento de tratamento prévio, eu acho que tem que indicar tratamento. O líquor, Não vai mudar aqui o que que a nossa recomendação, mas acho que só pela doença neurológica dela tem que fazer um líquor, sim. Eu acho válido fazer, mas o fato de também não ter um VD positivo no líquor não descarta sífilis. Mas acho que pela doença neurológica precisa de fazer, sim.
Perfeito. Então, como conduta, a gente vai investigar essa questão neurológica junto com a equipe da neuro, avaliar a coleta do líquor. O olho esquerdo indicar a injeção dos anti-VEGFs. No olho direito, sobre a panfoto,
Sim, faria panfoto.
faria
Sim.
panfoto também no olho direito. Perfeito.
Evitar neovascularizar, né? Tem muita área de isquemia.
Tem neovaso já também.
Beleza.
Uma
E
pergunta, o FTABS, quando é positivo, já não indica o tratamento?
não, porque ela pode ter tido sífilis, tratado e FTBS fica positivo.
Fica positivo.
Fica positivo.
Ele não
E
negativa o FTABS depois?
não,
Pode.
Não,
Ah,
o FTABS é a cicatriz sorológica, é o teste treponêmico. Então, ele vai, uma vez positivo, sempre positivo. O
Vai
marcador
ficar
de
sempre
cura é
positivo.
sempre positivo. O VDRL, que seria o nosso marcador de cura. Mas, assim, como ele é muito baixo, ou ela teve uma sífilis e tratou, ou seriam aqueles casos de sífilis tardia que ficam com o VD muito baixo, mas assim, uma sífilis tardia teria que ser uma sífilis do ponto de vista neurológico muito grave, ela não tem essa gravidade toda, mas assim, a gente acaba ficando com aquela dúvida e acaba tratando, né? Mas o FTA-ABS, o esperado é que fique positivo para sempre.
o
Eu
Carol,
só
você
queria
quer
pôr um
comentar?
ponto, pessoal, que eu acho que é importante aí nesse caso. Eu acho que trocar a experiência com o pessoal da Neuro, ouvir a opinião deles, acho que é fundamental nesse caso aí mesmo, viu? Porque tá estranho, né? As manifestações oculares podem ser de uma sífilis ocular já antiga, né? E com vasculites no olho esquerdo, e neurite também, e tudo. O outro olho, o olho direito, já com atrofia e tudo mais. E essa doença neurológica atípica, né? Eu acho que vale a pena ele passar pela neurologia mesmo. Acho que é fundamental, na verdade, porque a gente possa entender melhor esse caso, né? Que tem que ir adiante, viu, Calangaço? E vai lá na neuro trocar uma ideia com o pessoal aí, bater um papo com eles para que a gente possa dar o melhor tratamento para o paciente, que vai muito além do olho.
combinado, professor.
Ana, você quer comentar o que você está escrevendo no chat? Pode falar. Tá no.
Tá mudo,
Tá
Carol,
no.
seu microfone.
Ela não está
Não tá conectado.
tá
Na
aberta,
verdade,
mas
não
não
tá.
está conectada.
Peraí que eu tô com ela aqui do lado, ela vai usar meu áudio, então.
Meu computador não está muito bom hoje, está dando pau aqui. Eu vi alguns artigos que dizem que o Parkinson, principalmente nas fases mais tardias, pode levar a um estado de hipercoagulabilidade. Eu achei mais de um aqui. E outra coisa importante, tá dando uma... né?
Tem que desligar o seu.
Desliguei tudo.
Até o som do seu?
Já. Esse lado foi.
Mas pode continuar que dá para ouvir.
Acho que eu vou falar pelo do Túlio. Desliguei o meu aqui, abandonei o meu. E eu vi que a gente também não pesquisou nessa paciente outras moléculas que podem estar ligadas a um estado de hipercoagulabilidade. Proteína C, proteína S, fator 5 Leiden, que a gente poderia avaliar também. Mas me chamou a atenção que eu achei mais de um artigo. Aqui eu posso mandar para vocês falando dessa questão, inclusive que os pacientes com Parkinson têm um risco maior de tromboembolismo. Então, pode ser que a gente realmente esteja diante de uma paciente aí com Parkinson. É estranho um Parkinson tão precoce, mas que tem sim artigos que mostram que esses pacientes têm um risco de embolismo maior e um estado de hipercoagulabilidade. Acho que seria
Mas eu acho
interessante.
que o que está mais estranho no caso é o Parkinson no paciente de 41 anos, né, com oclusão nos dois olhos, sem outras comorbidades e com sífilis talvez positivo. Acho que eu não acreditaria muito no diagnóstico do Parkinson, para pensar em hipercoagulabilidade pelo Parkinson, né? Não sei.
Eu acho que a gente tem que conversar melhor com a neurologia para entender esse diagnóstico também, né?
Existe, né? Parkinson precoce existe, não é tão comum, mas existe. E investigar mesmo. Mas eu investigaria também outras causas para estados de hipercoagulabilidade que podem estar presentes.
Vamos organizar. Então, da parte, eu acho que vale a pena a gente ter uma avaliação da neuro para esse paciente para definir se é Parkinson ou não. Indicar o tratamento da neurosífilis e tratar, fazer no olho esquerdo, fazer anti-VEGF, olho direito fazer panfoto, tá? Quem que é o fellow que pode abraçar o caso aí? Que daí tem que pegar alguém, tem que pegar e...
Eu posso. Eu, inclusive, estou falando com um amigo meu que faz neuro. Já até passei um pouco o caso para ele.
Maravilha. E aí, Fred, depois que tiver essas conclusões, vamos representar esse caso que eu acho que é super interessante, tá? E aí,
pedir-
Luca e Gabriel, deixa naquela nossa pastinha de representações, por favor.
Você já me
pedir-
manda o número do prontuário, por favor, Henrique? Eu coloco no...
Pode deixar.
Valeu.
E Ferreira,
A
próximo.
gente já está com um número excelente de casos. Eu sempre falo, ó, esse aqui é para Graham, então a gente já está com uma pastinha bem legal aí.
Tá, joia. Então, com isso a gente encerrou a reunião. Só lembrar que a semana que vem, então, a reunião vai ser híbrida. Quem vai dar aula é a Juliana Salom.